when you're going to fall asleep. So, what is chronic illness and disease? Can someone just give us a definition? I'm not looking for rocket science, I just want a simple definition. Who will talk to me? Yes?
Symptoms of discomfort that influence of all the organ systems that never disappear for a long time.
Excellent. Symptoms of discomfort, pain, misery that involve some or many organs that never go away. That's a great definition. Here's the definition I came up with. I actually stole this from Wikipedia. A chronic disease is a disease or other human health condition that is persistent or long-standing in nature. For example, and you know the list, you've dealt with this is what you studied. I also want to make a comment about my approach today. Do we have any here who are not doctors or doctors in the training? Do we have nurses, health professionals who are going to be physical therapists, other kinds of health-related fields? Or all of you? Good. That's very good. I'd like to talk then about that role in today. I appreciate knowing you're here. Anybody else other than doctors? So all the rest of you going to go down the doctor route, huh? That's great. I wish you well. I'm excited for you. Not to be morbid, but death and disease are inevitable. You studied the second law of thermodynamics in physics, probably, and you learned about entropy. Everything goes downhill. I'm finding that my body's doing the same thing. I'm getting older. It's going downhill. Everything's breaking and not working as well. In many respects, the practice of medicine is about simply delaying death of the human body. Have you ever thought about the fact that you're entering a profession in which you're just going to delay death, which you can't ever win? Isn't that horrible? Well, while we're doing this for the human body, we have a chance to do a little bit more. It's my philosophy that living life is about enjoying life on this earth, even though we recognize death on the horizon, and our focus should be upon preparing for what's next. I want to show you some examples of chronic diseases today. It's what I promised in the syllabus, so here let's start. Let's talk about congestive heart failure. Let's talk about the mechanics of the heart. This is a sagittal view of sequential magnetic resonance images of a normal human heart. This is the right heart, this is the left heart, the aorta. And if you'll focus here, as it cuts through, you can see this structure, and you can see this area right there is the aortic valve. You can capture a look at three cusps on that valve right here, if you'll follow it through. Another time. Let's let it go through. This is, of course, the liver and the spine. So it is cutting from the patient's left side to the patient's right side. So the liver is getting better. Let's play this left one again, please. Let's play this one again, if you will. All right, starting from the patient's left, this is the left ventricle. Very thick walls, contracting circumferentially, as it should. Myocardial infarctions take out chunks of muscle, and it contracts in an unsynchronous pattern. This is a normal heart. It's very interesting to look at the anatomy of the heart. It's a very interesting, twisted structure with beautiful synchrony. It's the consistency of jelly. I don't know if you've ever touched a human heart in the operating room or seen it. You know when you get fresh chicken meat, fresh chicken breast meat, it's flabby and it's cold, it's soggy, it's just very, very wobbly. That's the way that the human heart looks when it's relaxed. It's not as much red as it is a whiter color. It's skeletal, it's not skeletal, it's cardiac muscle, special muscle. All right, let's play this one. I stole this from the internet as well. This orientation, the spine is here. I suspect this is a younger patient. This is probably umbilicus or something like an anterior abdominal structure, and sternum is here. Notice this structure is the aorta. And I want you to focus at that black line right there. Somebody tell me what's happening. Can we play that again? This is a contrast MRI. What do you see happening right here, this black line? There's backflow. That's exactly right. This is aortic regurgitation or aortic insufficiency. Now, I think that's what this is. It's not labeled on the internet. This could be a patient who's young, who has a congenital heart defect, and these may be unusual structures. This looks to me like a trilobular aortic valve structure. This would be the left ventricle, and this would be a jet of regurgitant blood, fast flow backwards during diastole. Please play it one more time. It's a very interesting technique, and this is very good quality film. I just found it very interesting to teach you what the mechanism. Okay, that's diastole. Here is systole now, and there's diastole, and that should not be happening. What's going to happen to this structure because of that jet? Yeah, it's going to enlarge because that tissue is the consistency of raw chicken meat. It's going to stretch, and when it stretches, what will happen?
It will lose its ability to contract properly.
It will lose its ability to contract properly. That's exactly right. Systolic force will be reduced. Frank Starling laws will take over, and you will have congestive heart failure. Pressure is increasing in the lungs, congestive heart failure, and eventually backing up into the right heart and peripheral edema. Okay, next slide. That's an example of a chronic disease. That particular patient doesn't have it yet, probably because they're young, but unless you replace that valve, they will by the time they're my age. Here are some other chronic diseases. Cancer is a great example of a chronic disease. Let's just take a look and understand that if you're going to have a cancer, you're probably going to have breast cancer, ladies, and you're probably going to have prostate cancer, men. That's your most likely thing. At least that's the United States statistics. But I want to make a point here that good doctors can diagnose particularly these two early, and they can be cured. You know that already. My question to you is, are you going to be that kind of doctor? Are you going to be able to detect that on radiology films one day? Are you going to be able to, in the pharmacy office, talk to that patient who mentions the breast lump to you and encourage her to go get checked before it's too late? How will we practice? Here's another example from Europe of chronic cancer. Survival rates. If you've got breast cancer, you're likely to be alive. You're about 85% likely to be alive after 1 year. Lung cancer is not so good. Only about 30% of patients survive a year. But people do survive a year. And you live with questions that don't get answered. You get diseases which go on. Do you recognize this man?
Steve Jobs.
That's Steve Jobs. He was the most probably well-known financial magnate, the chief officer of Apple Incorporated. He just died last month, if you didn't know that, from pancreatic cancer. His was a neuroendocrine type, a very rare type. He was 56 years old. He battled the disease for 7 years, including having a liver transplant before he died. During those 7 years, though, life went on for him. That's where you're going to come in. Chronic disease doesn't mean you throw in the towel and you give up. He was very productive. His doctors helped him keep going. But he left it all behind, didn't he? I want to tell you where I'm coming from, and I want to talk to you a little bit about your faith in God. I'm not going to assume that every one of you out there is a Christian, or a believer, or a follower of Jesus. I would hope you are. I am. I'm not apologetic about that, but I'm also scientific about it. I have looked at Scripture very hard. I have wrestled with the questions about evolution versus creation. I have made my own decisions about what I think Scripture says about science, and I can present my own beliefs about those things intelligently to my medical profession. I want you to be able to do that one day. I want you to process your faith at a deep enough level that you can be a very high-level professional, but also a very articulate Christian, if you are one. If you're not one, that's okay. I hope that my talk today will come at you in a neutral way that will engage you to think about why the spiritual element is important. I want to just tell you, though, that my orientation is that I think we're made up of three basic parts: mind, will, and emotions, which I call soul; the body, which is what we're treating as doctors, officially, and first; and the spirit. I believe as a doctor, we're foolish if we do not recognize all three parts. No matter what you believe about God, you probably recognize that there is some sort of a combination of parts of us that goes deeper than just skin deep. Even if you think that evolution created us and we're going to rot in the ground and that's final, you do love within marriage. You do enjoy the beautiful nature of the mountains and the sunrise and the ocean and whatever it is that you enjoy. There's an enjoyment part. Of course, there's more to us than just these bodies. This is my orientation, and this is where I'm coming to you today. But I want to encourage you to develop your own ability to articulate what you believe. Let's look at a great teacher, a great role model for us. If any of you attended my conference last year at Kharkiv, I talked about Jesus as a role model as physicians. At least Jesus was a great teacher. At least the Bible is a great work of literature, if it is not more than that for you. But I want to take a passage from the Scripture and point to you how well Jesus engaged a very intellectual person and how he used the correlation with and the contrast from the physical to point out the spiritual, okay? Now there was a Pharisee, a man named Nicodemus, who was a member of the Jewish ruling council. He came to Jesus at night. Jesus was available at night. Sometimes your patients won't talk to you other than inconvenient times, and you're going to have to balance your life, your private world, and your profession. You're going to have to decide when you can be available. It's not wrong to turn your beeper and your telephone off sometimes. But how available are you going to be? Are you going to be available so that you can make money? Or is it going to be to impact people's lives? If so, you might have to meet him at night. So here's Jesus meeting Nicodemus at night and said, "Rabbi, we know that you're a teacher who has come from God, for no one could perform the signs you are doing if God were not with him." What signs was he doing? He was mostly healing people's bodies, wasn't he? He was getting a lot of attention with that, even though he didn't really want that. Jesus replied, "Verily, very truly, I tell you, no one can see the kingdom of God unless you are born again, or born from above, or born on high." That's a very interesting statement, right to the heart of the matter. Jesus wasn't afraid to speak truth to an intellectual for the sake of stimulating the mind and opening conversation. He didn't refute him. He didn't say, "You fool. Why don't you understand this? You're supposed to be teaching it." He didn't insult him. He met him where he was, but gave him a bit of a controversial statement that made him think. I wonder how well we can do that. How skillful are we at being able to engage people intellectually and open the conversation for the spiritual? That's what I want to encourage you to do. How can someone be born when they're old? Nicodemus asks. Surely they cannot enter a second time into their mother's womb to be born. Look at his orientation, totally physical. Your patients are coming to you completely physical. I have this wart. I want it off my foot. I have this cough. I want it stopped. My hair is falling out. My temperature's going too low and I've got this rash on my skin. I can't pass my urine. My sexual function doesn't work anymore. What's wrong? Fix it, doctor. They're coming to you with physical complaints. Nicodemus's whole orientation was physical. In his response, Jesus answered, very truly I tell you, no one can enter the kingdom of God. Again, he's addressing the spiritual for the second time, unless they're born of water, that's the body, and the Spirit. Flesh gives birth to flesh, that's your mother. But the Spirit gives birth to spirit, that's salvation. You should not be surprised at my saying, Nicodemus, you must be born again. The wind blows wherever it pleases. Look at how he's drawing a correlation now to nature and things that can be understood to explain the spiritual. He says, the wind blows wherever it pleases. You hear its sound, but you can't tell where it comes from or where it's going. So it is with everyone born of the Spirit. Nicodemus, I'm trying to get you to experience something that you don't understand. Let's look at this. It's like being born, but it's not really being born. It's like the wind blowing, but it's not really the wind in the trees, is it? There's another dynamic. It's this dynamic. He's trying to tell Nicodemus that he has a spirit that needs to come alive. How many times have you thought about training to do that as a doctor? Let's talk about it. As doctors, we're going to have great privileges to engage patients at several levels. And I think chronic disease is one of those delightful ways to do it. Patients with chronic problems will drive you crazy. They will be at your door constantly. They will have lists of questions. They will take an hour in the examination room. I didn't make a whole lot of money in America because I spent too long in my examining rooms talking to patients. And I loved every minute of it. That's what I liked about practicing medicine. It wasn't just the fact that I was able to make money. It was because I had a chance to touch lives. Okay, let's look. We first must do no harm. That's the Hippocratic Oath. We must always be professional. And if you're a Christian and you're not doing your best in your studies, you might as well leave medical school, because we don't need believers who call themselves and push the idea that they're Christian and then do lousy medical work. That's an oxymoron in my mind. So please, shape up if you're not there. You don't have to make all A's. It's your desire. It's your drivenness. It's your purpose. That's what I'm questioning. Are you going to be professional? Are you going to know what you know and what you don't know and when to call your colleagues? Or are you just going to fake it and make up something and hurt the patient? That's an issue of the soul and the heart. And you're going to have to make those choices every day in your doctor's practice. Usually we diagnose and treat problems. Usually we answer questions. Sometimes we counsel and give advice. Maybe because we need to, or because patients ask us. Sometimes, and this gets a little more uncomfortable, we must confront and challenge patients. Mrs. Smith, why is it so hard to take your medicine? Your heart failure is getting worse. Your kidneys are failing more. You really need that ACE inhibitor. You need to use your Lasix every day, and you need to restrict the amount of fluid. Can you help me understand what's keeping you from doing what I'm asking you to do as your doctor? You don't come at Mrs. Smith and say, what are you, fool? What's wrong with you? Come on, let's get with the program here. You need to take your medicine. If you don't take your medicine, I'm not going to treat you. Get out of my office. Now, I know doctors who act like that. I don't think a whole lot of them. My encouragement is don't be like that. So sometimes we must confront and challenge. I would say do it in love and gentleness. Do it firmly when you need to. Sometimes we must say, I do not know. Could everybody say that out loud with me? I'd like you to practice it a lot. I do not know. Mrs. Smith, we've worked on this problem for 3 months now. You've seen me 6 times. And I've got to tell you that I don't know what's wrong with you still. I've tried my best. And today I want to introduce you to a colleague that I think can take this farther than I can. I'd like to call him up right now and make an appointment for you. Mrs. Jones, I don't know why that car ran over your daughter. I'm so sorry. But I'm here to help you put life back together. I know some people that can help you get through this. I'd like to introduce you to them, but I just don't know why this happened. I'm sorry. That's a real good thing to practice. Say it often and say it loudly. I don't know. I just don't know. That keeps you humble, and that's a good trait for doctors. And then, rarely, we get the privilege of talking about spiritual things in the medical encounter. Oh, we can force this. We can force people to talk about, every patient, you could evangelize. But no, you're not a pastor. You're a doctor. Okay? So I'm not about to encourage you to force spiritual conversations. But folks, they will arise. And when they do, don't run from them. Be prepared. Be excited about that. No one on this earth has a better opportunity to evangelize than a doctor. And it is done by example, not by words. It is done by time invested in relationship building. It is not done by preaching at your patients. So please don't do that. But don't run from those opportunities when they are searching. It's very easy to say, I know this is really hard for you. It would mean a lot to me if I could pray for you. How would you feel if we just prayed for a minute? Now that's not threatening. They can be Hindu, Muslim, Jewish, atheist, and they can still respond to that question with a polite yes or no, I'm not comfortable. Almost every patient that I ever asked that said, oh yes, doctor, please pray for me, no matter what their orientation of faith was. I was very surprised. I expected some turnoffs. I didn't get any, really, through the years of my practice. I practiced about 13 years. You know a lot, but you don't know it all. You're going to know a lot more when you get finished with this crazy process called medical training, but you're never going to know it all. So I want you to be humble. I want you to be approachable, because Jesus certainly was, even at night, even by scholars. Let them ask for help without punishing them for taking your time or asking you things that you don't know and embarrassing you because you have to say you don't know. There's a lot of ways that we punish our patients. Don't do that. Just let them ask. Build trust. And that is built on integrity and honesty and open dialogue. No one wants to see a doctor they can't trust. And unfortunately, what I see in Ukraine is patients shopping 5, 6, 8, 10 doctors to synthesize their own diagnosis out of all that because they don't trust any of them that they saw. My encouragement is be somebody they can trust and inspire confidence. Look people in the eye. Dress for success. Look like you mean that you want to be good. Know what you're doing. Study well and seek excellence in your work. Okay, everybody stand up. Let's stand up. Take a big breath. Stretch your hands over your head. Look forward to supper here in a few minutes. How about any questions? Sugar meter there and check your blood sugar around lunchtime. I'm proud of you that you do that. I know that's a lot of trouble for you. I really want to tell you I appreciate these numbers that you brought to me. It's going to help me treat you better. Judy, you're 18 years old, and no girl your age should have to take 5 medications. And I'm really sorry, but you know what? I'm proud of you that you are keeping up with all these medicines. Even if you miss one occasionally, that's no big deal. I just want you to know I'm proud of you. What you're doing is hard to do, and I think you're doing a good job. Those don't take but about 10 seconds, but it means the world to you patients. You'll make a friend for life. Can you imagine being talked to that way by a doctor? Has that ever happened to you? Would you show me your hands? Has that sort of conversation ever happened in your life in a doctor's office? Make it your point to do that at least once a day with somebody. Allow your patients to trust you. You don't need to become their best friend. That's dangerous. You don't need to date any of your patients. That's wrong. There needs to be objectivity, and you break that when you start treating family members and others who are close friends of yours, because then you become dangerous because you lose objectivity. But it's okay to let them become your friends. It's okay to develop a relationship, because in so doing, you can teach them to trust God rather than trust you or themselves. Okay, here are some negatives. Professionalism is not arrogance and pride. I remember a doctor, when I was a young student, screaming around the hospital ward something to the effect that I can turn my niceness on or off like a faucet, and I don't like what's been done here, and I'm not going to be nice today. Well, I don't think it's very commendable to turn on your pleasantness one day and turn it off the next. I mean, who'd want to be married to a man like that or have a professor like that? I bet some of you have professors like that, don't you? I sure had some like that. Medicine attracts some odd types. It really does. Building trust with patients is never a reason for manipulating them or abusing them. Sexually, mentally, to build your own medical practice, to feed your ego, to get money from them or to extort them, to do extra medical tests so their insurance company will pay you more money. Oh, the list can go on. Never is trust with patients a reason to abuse them. And then confidentiality. This is straightforward. You know this. You don't talk about things outside the medical practice that are shared with you in confidence. Enough said. Okay. Let's change gears a little bit. I want to just pose this to you. The key for treating illness, chronic illness effectively, is being willing to engage them on a spiritual level. Let's read that again. The key to treating chronic illness effectively is your being willing to engage patients on a spiritual level. But many of us are not willing to go there. Many of us don't feel comfortable with that. Maybe because we're not sure of our own spiritual issues. Why? I want you to talk to me now. This is another time I want to hear from you. Why is that first sentence possibly true? Crane up here thinks it's true. Do you think it's true? And if so, why? Why is engaging patients on a spiritual level a key to treating chronic illness effectively? Okay?
Even from the position of psychosomatic, if the person have problem inside, and this problem is everyday problem, so the illness in the body, it will be everyday illness. So if you solve the problem inside, you will solve the problem outside.
Excellent.
That's why in Europe nowadays psychosomatic is modern discipline in medicine.
Very good. This is a great example. Psychosomatic illness, the scared young housewife, afraid that maybe she's panicking over her husband leaving her, or she feels like she's got something inside her, growing inside her body, and she's fearing cancer or whatever. And you're dealing with something that's more mind than matter. Unless you can engage that spiritual, social, marriage, whatever it is that's eating that, you won't treat that disease. There are other things that I want to get out of this, though. That's a very good example. Yes, ma'am.
It helps them have the faith, like faith that they'll get better, spiritually, they develop that faith and confidence.
Very good. I want you to go deeper than that, but you're exactly right. Faith is what we're going for here. We're trying to help them develop the ability to have faith and use faith to interpret their illness. Let me go ahead and develop that while we're on it. The fact that we've got a disease that's never going to go away, let's take HIV and AIDS, for example, and you've got the stigma, whatever it is that you're dealing with about why you got it, And now these medicines that you can't afford, that are being given to you, that's the lifeline, and you've got to take them every day, and there's publicity about this in your family, and it's just, oh, there's levels of, okay, how to process this in a healthy way. How do we do that? Well, we've got to start asking the question, why? But the problem is we don't get answers to that question. Then it evolves to the question, how? How can this help me in my life? How can I help others with this disease? And I'm going to develop these ideas a little bit. So those kind of questions don't come out of medical textbooks. They come out of belief systems called faith. Faith in popularity, faith in money, faith in Hinduism, faith in God, faith in Jesus, faith in whatever. But a belief in M&M chocolate candies can change your life if you're really hooked on that and believe that it's going to save you and really help you overcome cancer. So yes, believing something dearly will change the course of medical treatment, but of course we want to take them deeper to the God who does have the answer to why and how and when am I going to die, and the other kinds of questions that are going to come. So I know you're probably thinking that way. I'm not going to call on you because I got to move on. I'm sorry. Thank you for being willing, though. Okay. So, diseases that won't ever go away change the doctor-patient relationship. From simple to complex, from acute to chronic, patients become dependent upon you at some level. Watch out, letting them become too dependent, wanting to see you every week in the office, trying to overuse their time with you because you're the only friend they've got. That happened to me regularly, and I had to barrier myself from that. My nurses were good at shielding me sometimes. Most importantly, you have the opportunity to partner with them, and that's the key word right there. Become the friend against the disease and help them cope. Spiritually, you can gain that better than if you don't engage the spiritual. You can do better with this process of partnering if you can introduce the spiritual, such as helping live with the questions about why me? Why did this happen to me? How do I understand why this happened to me? Why could it not have been someone else? Why does it have to be me? It's suffering. I mean, I've had patients, screaming that in my office. There's no good answer to that question. That's where you have to say, I don't know. But I do know someone who has the answer. Unfortunately, they're mad at God right at that time, and you're going to have to help them morph over from anger to God and denial to acceptance and get past bargaining to the point of neutrality and ability to listen to God. You've got to walk them through that grief process. We are effective if we can help them find answers to other questions like, how can life go on with this? How can I learn from this? Maybe I could help others who've got the same disease. And what's God wanting to really teach me? I mean, it's not that He's punishing me now. Dr. Crane has helped me understand this is not punishment, that the statistics show that 7 to 10% of good people get this bad disease. It's not my fault. I didn't cause this, but God's not punishing me either. So what good can come out of this, right? Okay, giving hope and encouragement can be better than medicine. And pharmacists do that regularly, just like doctors do. Offering a listening ear is always critically important. If you're not interruptible and able to sit down with your patient, you're going to lose a lot of confidence. Let me show you a very important diagnostic, and it's a diagnostic technique. It's an ability to open up conversation and develop the history. It looks like this. The process is just simply this. Isn't that pretty easy?
Yeah.
Most of us want to do this. Okay, Ms. Jones, go. Tell me about your problem. I got 10 people waiting outside that door. Even if you spend 1 minute with Mrs. Jones like this versus like this, and you gently and appropriately put your hand on her hand or say, I'm really interested, can you tell me what's wrong? I want to hear this in your words. And you only let her go for 1 minute. And your nurse pages you out, or you've got an interruption or whatever. Both at the same amount of time. What's Mrs. Jones going to feel? She's going to feel that you spent more time with you like this or like this. What do you think? Of course, she's going to think that you have spent more time with her sitting down. Studies have been done to prove this. Exit polls from doctors' offices. Your patients always think that you spent more time with them if you sit down. So practice sitting down beside your patients, making eye contact, smiling, or being empathetic, and just listening. Involving and teaching family and friends is a very important part of chronic illness management. They're good investment. Okay, let's jump to a real case. I'm going to show you some pictures of chronic rheumatoid arthritis. I'm going to tell you that I had patients like this in my practice. I'm going to show you some of the disease pathology because I want to teach you some science here and show you some real good pictures. But I also want to try to get you to think about how you help patients go on with life who have stuff that looks like this. Okay, so here you've got classic. What is this deformity right here? I didn't hear you. That's a swan neck deformity. Looks like a swan's neck. That's a classic rheumatoid arthritis. What is this one called? That's a boutonniere deformity, as if someone is buttoning a button and their fingers are up, pinched like that. So those are the classic rheumatoid arthritis changes of the flexor and extensor tendons because of the damages of the disease. These are rheumatoid nodules, classic ones, and I've seen many of them in my lifetime. Rheumatoid arthritis is not just a joint disease. It involves the brain, it involves the lungs, it involves connective tissue of all sorts, it involves many tissues. Predominantly, of course, the connective tissue, the bones and the tendons and such. But what do you know about this part of the body right here? The first and the second cervical vertebra. One's called the atlas and one's called the axis. How do they work with each other? Do you know that anatomy? Did you see it on a real cadaver? Have you seen a skeleton and studied this on a skeleton? What you don't understand with a skeleton is that there's a tendon that holds that process from whichever one it is, the atlas, the axis, the one that has the pointy thing that sticks down, the process that sticks down. There's a tendon, or a ligament, I should say, that holds that in place. And if that ligament is diseased, it gets soggy and flexible, which is classically what happens in rheumatoid arthritis, and it allows that to pith the spinal cord right behind it. So it allows flexibility. This is not the best picture. I also wanted to show you the loss of joint space here, and here, and here, and here. These intervertebral discs are just disease. This is classic synovitis, hyperblastic, hypertrophic synovial cells. Eventually there will be infiltration of multinucleated giant cells, and there will be scar formation, and fibroblasts will come in and create scar, which is permanent, and pannus. Pannus is the condition that usually has to be surgically removed to enable a joint to work again. This is a very severe example of the destruction of joints from rheumatoid arthritis, and an x-ray to show you. You can see fusion of joints. These joints are actually fused together here and here. Look at the loss of that one. That's not the way the thumb should look, and that's the corollary of inflammation from the nodule formation. Here is scleritis. Did you know that rheumatoid arthritis can affect the white part of the eye? It's called scleritis, and that's what it looks like. This is an example of the wrist opened up surgically. This is the extensor retinaculum peeled back. Look at this nodule here on that extensor tendon, probably to the index finger. If this were the left hand, that would be index finger. Here's another nodule, here, here. Notice the difference between this leg and this leg in this patient. This is swollen. This is the same patient a few days later. This is a ruptured popliteal cyst, and this is the radiographic image of that cyst. This is all a big, bullous fluid sac that's all part of the knee joint tissues. What should be the synovial package that's neatly confining the knee joint is now blebbed out and has become a huge sack of potatoes, sack of fluid. It's just bulging and slooping down. And this patient's ruptured, and it went down by gravity down the leg. And therefore you've got pressure, stasis changes, poor oxygenation of tissues, and death of blood cells, hematomas, and so forth. Okay. I'm going to end very quickly here, so I'm going to throw a question. I'd like a little discussion on this one, because this is real controversial in Ukraine. Should we tell our chronically ill patients that they're going to die? Should we open the discussion about this when we know death is near? What do you think? I'm going to ask somebody else. Hold on just a second. Yes, sir, at the back. You think yes. I'm going to stop you. I'm going to come back to you. Who else thinks yes?
I think
Got a few hands. Who thinks no? Be brave now. Raise your hand. You think no. Who else thinks no? You think no.
I think it's a family member.
I'm sorry?
It's a family member.
Family member? Is that what you said? Okay. I'm going to go back to the gentleman here. Why yes?
Because sometimes it's good to open up to the patient, tell what the life is all about, what she's going, he or she is going to face. So that maybe the patient is chronically and this is not thinking of the medicine that she will take. So you can open up to them. If you don't do this, you may die.
If we've exhausted all of our treatment options and we're at that point where we really have nothing else left, they are going to die unless we have a miracle or supernatural intervention. And, if we know that's going to happen, then you're really talking to them not about other treatment options that they may consider, but about palliative care, pain control, the end. Now, let's develop the idea. Why do family members get the privilege of knowing that someone's going out into eternity rather than the actual person who's going out into eternity? Why does this work for you that way? Help me understand that better.
The patient is already dying, so there's no need of telling what's in the street of telling he's going to die again. But
Patient's already dying. Let me just make sure everyone's understanding. You said that the patient's already dying. So they're not the one who needs to understand that death is imminent. The family needs to be prepared. Is that what you said? Help me develop that some more. I don't believe that. Keep going. You got to convince me. You got to help me here.
the family members are like, they are still healthy, but they can accept the bad news. But the other person on the other hand is ill already. So the bad news will make the situation worse.
And you make upset the patient by telling them that they're going to die. I couldn't agree more. I do agree with you that can be dangerous. And I have been in situations in which we chose not to tell a patient. But I want you to know that the doctor up here standing in front of you who has treated many patients dying of chronic diseases, where they did die, almost everyone, I told them that they were preparing to die. And I told them in words like this. Listen carefully. Mr. Smith, we've worked along hard on this illness. He knows that. He's been the one who's having to come to my office and take all these medicines and do all this horrible radiation and stuff. We've worked really hard on this, and I appreciate both your partnership with me and your own willingness to go through all this. Our results have not been as good as either you or I would like. I'm kind of discouraged today. What about you? You give them a chance to say something. What do you think's next? Now, have I told the patient he was going to die? I basically did. The question is a loaded one, right? I said, what do you think's next? What's next for you? I want you to know something, Mr. Smith. I am here for you no matter what. And I'm here for you and your family. What do you want at this point? What can I do for you? You are just simply laying it open for the discussion to happen. You're giving Mr. Smith the opportunity to say, I think I'm going to die. And if he says that, you say, by George, you're right, you're going to die. It's probably going to be next week. Of course not. You never tell a patient when they're going to die because you never know. You may think you know, but I've been very surprised many times. So you say, well, Mr. Smith, I understand. How do you feel that way? I mean, that really makes sense to me too. Now, have I told them they're going to die? I've simply agreed with what they said. You see what I'm doing? Now that's called empathy. That's called walking them through the obvious. That's helping them prepare for death. Then I ask the question, Mr. Smith, what do you think? Do you think you're ready to face what's next? I didn't use the word death. I didn't use the word eternity. That's religious. That's church talk. I can talk church talk, but I said, do you think you're ready to face what's next? Well, Dr. Crane, I don't know. I just don't know. I'm so scared. I don't know what to do right now. I wish somebody could help me. Mr. Smith, I'm here to help you. Do you have a pastor that you trust? That's a two-part question. Do you have a pastor that you trust? Because if they have a pastor who's never talked to them and they've never talked, that's not a good fit. And you got to deal with that before you bring that person in. Do you have a pastor or someone who can help you spiritually that you trust? That's where you, as the physician, start gluing together the opportunities for them to prepare for death without you having to take your time in the office to do it or the full responsibility. Now, if the opportunity is right there before you and you can help them and walk them through a conversion experience and a salvation prayer, great. I believe that God chooses us, and I believe that He gives us choice. It's an amazing dichotomy that makes no scientific sense, but I believe both are equally true. And so in the scheme of this Mr. Smith is being drawn to the kingdom of God through this medical illness, and you are simply the navigator of the murky waters for him. You're simply pointing him to the way, to the light. See it that way, and you don't have to get tangled up with the yes or no part of this question, see? Now, I've just given you my philosophy. I respect you totally if you don't agree with me. I have a feeling that most of your professors in Ukraine are telling you, no, you should never tell a patient they're going to die. It may destroy them. It may cause them to die. It may upset them. It may condition them worse. Tell the family. I don't agree with them. So this is a very good entry to what medicine's all about. Full of controversy, no good question, no good answers. That's the way you're going to live the rest of your life. Not a lot of good answers. In conclusion, strive for excellence. Nobody likes a sloppy and careless doctor. Be the very best professional that you can. Show empathy, show compassion. Get down at the patient's level. Talk to them as your respectful equal. Help them to understand you are there for them. And be what you would want if you were the one in their shoes. Become a partner against disease. Help them find meaning by openly and honestly discussing God in a real and legitimate way. Don't preach at your patients. Thank you for being here. Thank you that you care. I'm proud of every one of you. I've enjoyed talking with several of you out in the hall today and tonight, and I'm happy to speak with any others of you who would like some time with me. Have a good meal. What's next, Rusty? Is it photographs? Is that